Hello, this is Mrs. Page, and this lecture will cover acute coronary syndromes. Coronary artery disease is a broad term that includes chronic stable angina and acute coronary syndromes, or ACS. It affects the arteries that provide blood, oxygen, and nutrients to the myocardium. When blood flow through the coronary arteries is partially or completely blocked, ischemia and infarction of the myocardium can result. Ischemia occurs when there's insufficient oxygen supplied to meet the requirements of the cardiac muscle. Infarction or necrosis occurs when severe ischemia is prolonged and decreased perfusion causes irreversible damage to the myocardium. Here are the objectives that we will cover in this recorded lecture. If you want to pause and look these over. When we talk about coronary circulation, it is referring to the circulation to the myocardium or the heart muscle. There's two arteries that supply the blood to the heart muscle, and they branch from the aorta. The right coronary artery supplies the right atrium and the right ventricle, and also the SA and AV nodes. You can see the right coronary artery is here. The left coronary artery supplies the left ventricle, the left atrium, the septum, and the apex. And it also splits into the left anterior descending and circumflex arteries. And you can see the left coronary artery is here, and it splits into the LAD and the circumflex. Then the blood is returned to the right atrium through a large coronary vein. Also think that the collateral circulation can develop if blood supply to the myocardium is occluded. So if any of these arteries are occluded, collateral circulation can occur where it goes around that blockage to provide blood flow to the myocardium. Coronary artery disease is obstruction from atherosclerotic plaque that impedes blood flow. It decreases the supply of oxygen to the myocardium. If the demand for oxygen increases, such as during times of exercise or stress, the supply cannot meet the demand, and that leads to ischemia, which can result in infarction. Factors that contribute to myocardial ischemia is coronary perfusion, myocardial workload, and blood oxygen content. Coronary artery disease is the single largest killer of American men and women in all ethnic groups. Atherosclerosis is the primary factor in the development of coronary artery disease. Non-modifiable risk factors include age, gender, family history. Non-Hispanic Black males are at the highest risk of coronary artery disease, followed by non-Hispanic white males. Age is the most important risk factor for developing coronary artery disease in women. Modifiable risk factors include tobacco use, diet, and weight. Metabolic syndrome is also a risk factor for coronary artery disease, and metabolic syndrome includes three of the following: hypertension, decreased HDL levels, increased levels of triglycerides, increased fasting blood glucose, and a large waist size or excessive abdominal fat. And metabolic syndrome is most commonly seen in females. Usually the first MI is going to be seen in men around the age of 65, whereas the first MI will be seen in women around the age of 72. And every 84 seconds, someone dies from coronary artery disease. Angina pectoris, or commonly referred to just as angina, is chest pain that's caused by a temporary imbalance between the coronary artery's ability to supply oxygen and the cardiac muscle's demand for oxygen. Acute coronary syndrome is used to describe patients who have either unstable angina or acute myocardial infarction. It's believed that the atherosclerotic plaque in the coronary artery ruptures, resulting in platelet aggregation, thrombus formation, and vasoconstriction. The amount of disruption of the plaque is going to determine the degree of coronary artery obstruction. and once the artery reaches about 50% occlusion, blood flow will be impaired. Chronic stable angina is chest discomfort that occurs with moderate to prolonged exertion in a pattern that is familiar to the patient. This is associated with fixed atherosclerotic plaque, and usually this angina is relieved by nitroglycerin or rest, or it's managed with drug therapy. Unstable angina is chest pain or discomfort that occurs at rest or with exertion and causes severe activity limitation. The patient might have stable angina that can develop into unstable angina if the angina increases in the number of attacks or if it changes in the intensity of pressure. Unstable angina may last longer than 15 minutes, or it may be poorly relieved by nitroglycerin or rest. You might see ST changes on the EKG, but you will not have changes in the troponin with unstable angina. Ischemia is present with unstable angina, but it's not severe enough to cause detectable myocardial damage or cell death. There are different types of unstable angina that you can see. New onset angina is when there's first angina symptoms, usually after exertion or other increased demands of the heart. Vasospastic angina is chest pain resulting from coronary artery spasms, and these typically occur after resting. And pre-infarction angina is chest pain that occurs in the days or weeks before an MI occurs. Myocardial infarction, acute myocardial infarction, acute MI or heart attack, those are all terms that can be used interchangeably. So an MI occurs when myocardial tissue is abruptly and severely deprived of oxygen. The ischemia can lead to injury and necrosis if blood flow to the myocardium is not restored. Got two different types of myocardial infarctions. There's non-STEMI and STEMI. Non-STEMI or in-STEMI will typically have ST depression and T-wave inversion on the EKG. This indicates myocardial ischemia. And initially the troponin may be normal, but it will elevate in 3 to 12 hours. In your STEMI patients, they will have ST elevation in 2 contiguous leads on a 12-lead EKG. This is when a STEMI is caused by a rupture of a plaque that leads to platelet aggregation and thrombus formation. And at the site of this rupture, it leads to 100% occlusion of the coronary artery, and this is considered a medical emergency. Assessment of your patients that have coronary artery disease, you want to first start with history. Ask them about their cardiac history, family history, risk factors such as eating habits, their lifestyle, physical activity levels, and smoking and alcohol use. Next, we'll move on to pain. The rapid assessment of the patient with chest pain is crucial. You need to ask a full pain assessment, so onset, location, radiation, intensity, duration, precipitating or relieving factors. Does the pain radiate to the chest, epigastric area, jaw, back, shoulder, or arm? The chest pain might be described as tightness, discomfort, a burning sensation, pressure, or indigestion. Women might experience pain between the shoulder, in the jaw, or a choking sensation. They might describe it more as indigestion or heartburn. When a patient is having an MI, discomfort with the MI is not relieved with rest or nitroglycerin. You also want to ask about associated symptoms such as nausea, vomiting, diaphoresis, dizziness, weakness, palpitations, and shortness of breath. So the more of an occlusion the MI has, the worse the symptoms will be. Next, you'll look at vital signs, blood pressure and heart rate. Also look at EKG, looking for dysrhythmias. Usually, sinus tachycardia with PVCs will frequently occur prior to an MI. Listen to heart sounds. You might hear S3, which will indicate heart failure, which is a common complication of MIs. Respiratory rate and breath sounds should be assessed for signs of heart failure. Pulses should be palpable. With an MI, you might feel thready or weak pulses. Skin temperature should be warm, but with an MI, you might see cool, clammy skin. And psychosocial assessment. If a patient is having an MI, you might see denial, anxiety, fear, depression, or anger. Signs and symptoms of coronary artery disease focus a lot on pain. That's why it's really important to get a pain assessment on these patients. We'll compare angina signs and symptoms to MI signs and symptoms. So angina, you'll see substernal chest discomfort. It might radiate to the left arm, and it's precipitated by exertion or stress. Or if they have vasospastic angina, it can occur with rest. Usually angina is relieved by nitroglycerin or rest. It lasts less than 15 minutes, and there's few, if any, associated symptoms. With a myocardial infarction, the pain or discomfort will be in the substernal chest area, and it can radiate to the left arm. You might also see pain or discomfort in the jaw, back, shoulder, or abdomen. The pain will occur without cause, and usually it'll start in the morning. This pain is relieved only by opioids, specifically morphine, and the pain will last more than 15 minutes. There will also be frequent associated symptoms such as nausea and vomiting, indigestion, diaphoresis, dyspnea, feelings of fear, anxiety, dysrhythmias, most commonly ventricular fibrillation, fatigue, palpitations, dizziness, disorientation. The skin will become a pale ashen color, and the skin will be cool and clammy. Women are more likely to experience atypical angina, manifesting as indigestion, pain between the shoulders, an aching jaw, or a choking sensation. Older adults are also more likely to have these atypical symptoms instead of the chest pain or pressure. Occasionally, your patients might have a silent MI where they don't present with any signs and symptoms, and it's accidentally picked up by a routine EKG or physical exam with an EKG. This is common in your elderly patients that are greater than 85, and it's due to collateral circulation development. So that's why they don't present with those signs and symptoms, because they have that collateral circulation. The 3 I's of an MI. So an MI is going to go through 3 stages. The first stage is ischemia, which results from inadequate blood flow to an area of the heart and causes pain. The pain persists despite rest and nitroglycerin. The patient will need treatment without delay to prevent permanent damage to the tissue. The window of opportunity, which you might hear, this refers to the 4 to 6 hours within the onset of signs and symptoms where that ischemia can be reversed. And usually it is best if treated within 2 hours of the onset of chest pain. The second I is injury. This occurs when there's continued inadequate blood flow to the area and injury to the tissue develops. And the third I is infarction or necrosis. And this is death of the tissue due to decreased or no blood supply, and this is irreversible. So the contractility of the muscle, the myocardium, is permanently lost. And the size of the infarct is going to depend on how quickly the blocked artery can be restored. So if the blocked artery is never restored, it's going to lead to permanent cardiac death, which will cause death of the patient. Whereas if there is an infarct and it's treated within an hour or so, that injury, the infarction won't be as big and won't cause as much damage. Labs and diagnostic tests for acute coronary syndromes. An EKG should be completed within 10 minutes of the patient stating that they have chest pain, whether if they come in the ER or if they're inpatient and they tell someone that they have chest pain. Depending on what leads the EKG changes are in, will tell the provider where the ischemia is occurring or if the where the infarction is occurring. Ischemia shows as ST depression, T-wave inversion, or both of them, and this is common in unstable angina and non-STEMIs. A STEMI will show ST elevation. You might also see a Q-wave develop, and it will take hours to days for the ST segment and the T-wave to return to normal. Troponin levels, troponin T and troponin I are specific for MI and cardiac necrosis. They will rise quickly, and they're usually repeated after 3 hours. So usually it takes about 3 hours for that troponin to elevate. So if they come in to the ER or if they say that they have chest pain, a troponin level will be drawn. And then in 3 hours after that, we'll recheck the troponin, redraw the troponin to see if it's elevated. If a patient has a negative EKG and negative tropes, but they still have chest pain, they're going to need more extensive diagnostic tests to figure out what's causing that chest pain. They might also get more extensive testing if they are diagnosed with a non-STEMI or STEMI as well. The cath lab encompasses a lot of different procedures. A cardiac cath can be done to determine the extent and the exact location of the coronary artery obstruction. The doctor will make a needle puncture through the skin into a large blood vessel, and a small tube called a sheath will be inserted into the vessel. The doctor will guide that catheter into the vessel through the sheath, and a video screen will show the position of the catheter as it's threaded through the major blood vessels and to the heart. The patient might feel some pressure in the groin, but they shouldn't feel any type of pain. And a cardiac cath can either go through the femoral artery or it can also go through the radial artery. It depends on the patient and what the provider prefers. Various instruments might be placed at the tip of the catheter. They include instruments to measure the pressure of blood in each heart chamber and in the blood vessels connected to the heart. It can be used to view the interior of the blood vessels. Can also take blood samples from different parts of the heart or remove a tissue sample or a biopsy from inside the heart. So when a catheter is used to inject a dye that can be seen on the x-rays, this procedure is called an angiography. When a catheter is used to clear a narrowed or blocked artery, this procedure is called an angioplasty or percutaneous coronary intervention or PCI. When a catheter is used to widen a narrowed heart valve opening, this procedure is called valvuloplasty. So all of those procedures are done in the cath lab, just depends on what type of instrument they're using with that catheter. A stress test can be done after the acute stages of a acute coronary syndrome to assess for EKG changes during exercise or to help identify who would benefit from invasive therapy such as a cardiac cath. Chest x-ray can be done to rule out aortic dissection, which can mimic signs and symptoms of an MI. Thallium scans use radioisotopes, so cold spots or darker areas on the image will identify ischemia or infarction in your thallium scans. Contrast-enhanced cardiovascular magnetic resonance or imaging or a cardiac MRI or a CTCA, a computed tomography coronary angiography, or a cardiac CT scan, can help detect coronary artery disease, just gives us a better picture. And an echocardiography can help visualize the structures of the heart. Our EKG is going to be a main diagnostic test used for patients that come in with chest pain or signs and symptoms of an MI. So depending on what EKG leads have changes, it's going to correlate with where the infarct is. So for example, if there's changes in leads V1 through V4, it's affecting the LAD, and it's causing an anterior or septal infarct. You can see this is where that changes in V1 through V4, that's where your infarct would be. If there are changes in lead 1, AVL, and V5 through V6, it's affecting the left circumflex artery or a diagonal of the left anterior descending artery, and it's causing a lateral infarct. And you can see here it would be on the lateral side of the heart. This is just a better way for the doctors to determine where the heart attack is occurring. Treatment for an MI is designed to keep the area of death from getting bigger. Remember, time is muscle, so the quicker the oxygen is delivered to the patient, the slower the death of the cardiac muscle is growing. Treatment includes CPR, oxygen, nitroglycerin, bed rest, and antidysrhythmics. Getting to the hospital within 2 hours of onset of chest pain greatly improves the chances of recovery and minimizes injury to the heart muscle. Treatment of patients that have acute coronary syndromes. So emergency care of a patient with chest discomfort, and this can start in the ER or it might start if they're already in the hospital. It can really start anywhere. You want to assess airway, breathing, and circulation, your ABCs. You want to put them on a continuous EKG monitor and get a 12-lead EKG as well. Ask the patient their description of pain, get a full pain assessment, check vital signs, get IV access, consult the chest pain protocol or notify the healthcare provider or call a rapid response team depending on what unit you're working in. Obtain a 12-lead EKG within 10 minutes of the report of chest pain. Providing medications, usually this is going to be morphine, nitroglycerin, and aspirin. Remember MONA. So morphine, oxygen, nitro, and aspirin. Morphine helps decrease pain, which decreases myocardial oxygen demand. It also relaxes smooth muscle and reduces circulating catecholamines, epi and norepi. Usually, morphine is given 2 to 4 milligrams every 5 to 15 minutes. Make sure to watch for respiratory depression, bradycardia, and vomiting with morphine. Aspirin inhibits platelet aggregation and vasoconstriction, which decreases the likelihood of thrombosis. If a patient has new onset angina at home, tell them to chew 325 milligrams of aspirin and call 911. If the patient comes in by ambulance, usually the EMTs or paramedics will have already given them aspirin and they should have oxygen on. If they don't have oxygen on, administer supplemental oxygen to maintain an oxygen saturation of greater than 90%. Also, put them in a high Fowler's position, provide a calm environment, and explain interventions to help reduce anxiety, which is going to reduce that myocardial demand. Assess vital signs and pain 5 minutes after nitroglycerin sublingual. If the vital signs are stable and the patient is still having pain, then give them another nitroglycerin. The max is 3 doses of nitro. You want to check the pain every 5 minutes. Usually, angina will respond to nitroglycerin by decreasing the pain or making it go away completely. If the patient is still having intense chest pain after 3 doses of nitro, it's going to signal an MI. Not always, but more than likely it will signal an MI. If chest pain doesn't improve after 3 doses of nitro sublingual, the healthcare provider might switch to nitro IV. You want to start this infusion slowly and monitor blood pressure. Also check for headache. That's a big side effect of nitroglycerin. The dose of nitro IV is increased until the pain is relieved, or the blood pressure decreases, or the maximum dose is reached. If the patient is receiving nitrates long term, there should be about an 8 to 12 hour period of that they're nitrate free to prevent tolerance. So a patient that's getting IV nitro will, if they've had it for a longer period of time, they're going to have periods where they are off of that nitro so that they don't build up a tolerance. If the patient is having headaches with the nitroglycerin, then you can administer acetaminophen with it. You also want to notify the healthcare provider if vitals deteriorate or a dysrhythmia occurs. Medications will also be given to increase myocardial tissue perfusion. Ideally, perfusion to the myocardium should be restored within 4 to 6 hours for a non-STEMI and 60 to 90 minutes for a STEMI. Remember, with patients that have a STEMI, they're immediately going to go to cath lab because they need to break up that occlusion because they're having a 100% occlusion there. Anticoagulation therapy is used to prevent clot formation. The most common anticoagulant you'll see for non-STEMI is heparin IV. Platelet inhibitors such as clopidogrel or Plavix is used as an initial loading dose, and then they'll take this daily for up to 12 months after the diagnosis. And this prevents platelets from clumping together to form clots. Beta blockers once a day will help decrease the size of the infarct and decrease the occurrence of ventricular dysrhythmias. Remember, beta blockers slow the heart rate and decrease the force of contraction, which helps myocardial perfusion, increase myocardial perfusion. Unless it is contraindicated, this patient will more than likely be discharged on beta blockers. ACE inhibitors or ARBs are used to prevent ventricular remodeling and prevent development of heart failure, which is a common complication after an MI. Calcium channel blockers can be used to help vasodilation and increase myocardial perfusion. Calcium channel blockers are used a lot for patients with vasospastic angina or patients with hypertension despite the use of beta blockers. And statin therapy can also be used to help reduce the risk of developing a recurrent MI or a stroke, and usually they'll be discharged with this medication. Reperfusion therapy. So depending on the location and the skill set of the hospital, one of two reperfusion strategies can be used: thrombolytic therapy or percutaneous coronary intervention, or PCI. Thrombolytic therapy dissolves the thrombi in the coronary arteries and restores myocardial blood flow. TPA, alteplase, reteplase, or tenecteplase, those are all the different types of thrombolytics. Remember, your patient has a high risk of bleeding with these medications. There's a lot of contraindications for thrombolytic therapy, and on page 761 of your book, it has a table that lists these contraindications. So if they've recently had a head injury, they're probably not going to get the thrombolytics. If they're on anticoagulants already, they won't receive the thrombolytics. Patients that cannot receive a timely PCI and they have indications of a STEMI, they need to be considered for thrombolytic therapy. So maybe the hospital that they're at doesn't have a cath lab, or the cath lab is full, or the nearest cath lab is too far away. That would be a reason that the patient should be considered for thrombolytic therapy. Thrombolytic therapy should be administered within 30 minutes of arriving to the hospital, and this is only considered for STEMI patients. Thrombolytic therapy is not considered for non-STEMI patients. People who receive thrombolytics will need a PCI anyways for a more definitive treatment. So thrombolytics dissolves a clot, whereas a PCI is opening that clotted area. So it makes more sense for them to go to the cath lab immediately. But again, not all hospitals will have a cath lab or one nearby. A PCI, again, is percutaneous coronary intervention, and also a patient might have to go and have a CABG or open heart surgery or coronary artery bypass graft. And all of this depends on how bad the occlusion is and how the patient needs to be treated. PCI is an invasive but non-surgical technique that is the treatment of choice to reopen the clotted coronary artery and help restore perfusion. The goal is to perform the PCI within 90 minutes of an acute STEMI diagnosis. This doesn't mean that non-STEMIs won't have PCIs, but the 90 minutes does not apply to a non-STEMI. It's really just that we want to get a STEMI patient into the cath lab in less than 90 minutes. So the PCI is performed in the cardiac cath lab. It includes clot retrieval, coronary angioplasty, which is when they insert the balloon to stretch that vessel, and a stent placement to help keep the vessel open. And if a patient has a STEMI and they're getting a PCI, the clot is retrieved. If the patient has a non-STEMI and they're getting a PCI, really they're just looking for the narrowing, and they might go in there and do a balloon and stent. The patient will receive heparin during the PCI to prevent clotting on the wires and the catheters, and usually it's stopped after the procedure. I'm going to play a video for you guys that shows a PCI.
Coronary arteries are blood vessels that take blood and oxygen to the heart muscle itself. If the blockages are very extensive, involve a lot of areas in the circulation, people may get chest discomfort, chest pains, shortness of breath. My name is Dr. Murat Tuzcu. I'm an interventional cardiologist. I'm the chairman of cardiovascular medicine at the Cleveland Clinic Abu Dhabi. I'm also the chief academic officer. Here I'm very fortunate to work with 4 other interventional cardiologists. Patients should be evaluated carefully. We may choose one of 3 ways. 1, we may treat the patient by medicines and lifestyle changes. Number 2, we may choose to treat the blockages with stents, or if the blockages are very extensive, involve a lot of areas in the circulation, we may choose to perform bypass surgery. If we choose stents, we call that type of treatment PCI, that stands for percutaneous coronary intervention, meaning that we don't make a cut, but work through tiny holes from groin or the wrist and advance a tiny catheter to take pictures of the blood vessels supplying the heart and identify the problem areas. Right here, you see the blood vessel is narrowed by the fatty buildup in the wall. In order to treat this narrowing, we thread a tiny wire across it, or this wire. We advance a long balloon and place it right across the narrowing. Inflate the balloon that expands the artery. We take the balloon out, and we advance a stent mounted on a balloon into the opening right across the obstruction, inflate the balloon, expand the stent, then we deflate the balloon, take the balloon and the wire out. Now we are left with an expanded, opened narrowing. Patient is transferred from the cath lab to the ward and rests the remaining hours of the day. And next day, we check the patient's access site, we check the blood work, we check the EKG, and if everything is okay, most of the time we're able to send the patient home. After going home, we make sure that they take some of the medications very, very religiously, but they will be able to resume their daily activities very shortly. It's critically important patient adheres to a healthy diet, regular exercise, maintain an ideal body weight, and takes this medication. Most will agree that the heart disease is probably the most threatening disease that we know of. It doesn't only kill, it also leaves you incapacitated or very limited. That's why I think that the early detection and treatment of heart disease is critically important. We don't want people to have heart attacks. We don't want people to have sudden death. So if they have any symptoms, they should seek medical attention.
Coronary artery bypass graft, or CABG, or open heart surgery might also be done. This is not as common because of the ease and safety of PCI, but it is indicated when patients don't respond to medical management of coronary artery disease or if the disease progression is evident. And the surgery is based on the patient's symptoms and the result of the cardiac cath.
Coronary bypass surgery is, as the name suggests, when you get a blockage in your coronary vessel. To treat that, you have 2 possible ways. One is to put a stent and push that narrowing or stenosis open. Another option is to actually bypass it. And in coronary artery bypass surgery, what we do is we bypass that blockage. We leave that blockage in place, but we go beyond that blockage and feed that vessel with a new inlet for a fresh blood supply.
There are three major blood vessels that supply blood to the heart. The left coronary artery, which divides into two major branches, and then the right coronary artery. And patients can develop blockages in those arteries that lead to heart disease. Coronary bypass surgery is utilizing either a vein or an artery to bypass the blockages. And the bypasses are usually placed in a location that is far beyond the blockage, thereby not only treating the blockage that's occurring at present, but also treating future blockages for most patients.
You do as many bypasses as necessary to achieve what's called a complete revascularization, meaning that you have bypassed every single significant or sizable vessel to all major territories of the heart.
Cleveland Clinic, for the most part, invented coronary bypass surgery back in the 1960s. Mason Soanes was a cardiologist who happened upon coronary angiography and developed really the first coronary angiogram. And together with his surgical colleague, Rene Favillaro, they worked and were able to do the first coronary bypass. And coronary bypass surgery had a tremendous history here at the Cleveland Clinic from the early 1970s. We did far more coronary bypass surgeries here than anywhere else in the world. Coronary artery bypass surgery is certainly the most common operation that heart surgeons perform, and it's actually the most common operation among heart surgery programs in the country. But that doesn't mean that it's the same operation for every patient. Every patient needs a tailored approach to coronary revascularization. So there are multiple approaches for coronary artery bypass surgery. The standard approach is utilizing a full sternotomy, which is a full splitting of the sternum. And the surgery can be performed either utilizing the heart-lung machine or what's called off-pump technique, and thereby we use stabilizers to stabilize portions of the heart to do the bypasses we need to do. We can also perform minimally invasive coronary bypass surgery. A lot of those can be performed through a very small incision between the ribs.
We never want to compromise quality for cosmetics, because our objective is not to have a perfect immediate outcome. Our objective is to have long-term success.
When we look at performing bypass surgery, we use either the mammary artery, a radial artery from the arm, or a portion of the saphenous vein from the leg. Now, each of these bypasses lasts a certain length of time. They don't last forever. The mammary artery by far lasts the longest. It's one of the only arteries in the body that really does not develop atherosclerosis. So multi-arterial grafting is by far the best strategy for performing coronary artery bypasses for patients because it gives the most long-lasting effect.
Not only do we have high-volume cardiac surgery practicing, but the patients we get here are very high-risk patients. We accept patients from all over the country, in fact, from all over the world. Many of them have seen 1, 2, or more surgeons that have declined to offer those patients surgery because of their high risk. And the surgeons here are very comfortable dealing with those patients.
The Cleveland Clinic has long been a leader in reoperative coronary artery bypass surgery. That is, new coronary bypasses in someone who's had bypass surgery before. We do the largest number of those cases yearly than any other center.
What we do to achieve excellent results is having a great team approach. We have excellent surgeons, we have excellent support.
Preoperatively, before a open heart surgery, you want to make sure that these surgical sites, the hair on them are clipped. They need a CHG bath, and usually they'll get IV antibiotics about an hour prior. Typically, the aspirin or Coumadin will be held 4 to 7 days before surgery, and if they're receiving heparin, it's stopped about 4 hours prior to surgery. You want to teach the patient about possible endotracheal tube, chest tube, IV lines, urinary catheter. The patient will have incisions on the sternum and the leg, and coughing and deep breathing exercises. So you want to prepare the patient and the family for everything that they will see and everything they'll need to do post-operatively. They are MPO after midnight. They need an anesthesiology assessment, and they'll have to sign consent form, and there will be baseline labs, EKG, and chest x-ray. When they are in the procedure, there is cardiopulmonary bypass. It's used to divert blood from the heart to the bypass machine, where it's heparinized, oxygenated, and returned to the circulation through a cannula that's placed in the ascending aortic arch or the femoral artery. The core temperature of the patient is cooled to about 95 degrees to 98 degrees. The heart is perfused with a potassium solution, which stops the heart, so there is a motionless operative field, so the heart's not beating while they're operating on this. The surgeon will use an artery or a vein to bypass the blockages in the coronary arteries. Then the heart is rewarmed slowly, it regains the rate and rhythm, or they might have to defibrillate it to return it to the normal rhythm. Temporary pacing wires and chest tubes are sewn in, and then the sternum is wired and closed shut. Post-operatively, they'll be transferred to a post-open heart surgery unit. They need to be monitored for dysrhythmias, hypoxemia, hypokalemia, fluid and electrolyte imbalances, hypotension, hypothermia, hypertension, bleeding, cardiac tamponade, decreased level of consciousness, anginal pain, and surgical site infections. You'll want to maintain their chest tubes. You'll also need to differentiate between sternotomy pain from the surgery and the incision and anginal pain, which can signal that there was a failure in the graft. Sternotomy pain is not going to radiate, and it often becomes worse when coughing or breathing deeply. Mechanical ventilation is continued until the patient is hemodynamically stable and breathing is adequate. Usually this is about 3 to 6 hours after surgery. The number one complication of CABG is atelectasis. So encourage turning, coughing, deep breathing, and the incentive spirometer. And usually now the patient will be up in a chair about 4 to 8 hours after extubation. And the day after surgery, they should be ambulating 25 to 100 feet about 3 times a day as tolerated. Patient education, usually it's about a 6 to 8 week recovery period. The incision sites should be inspected daily for signs of infection. The donor site care, so if they had a femoral artery graft, they need to avoid crossing the legs. They should wear elastic stockings until edema subsides, and they should elevate the surgical limb when they are sitting in a chair. If they use the radial artery, they need to open and close the hand vigorously about 10 times every 2 hours. Cardiac drugs, aspirin, beta blockers, calcium channel blockers, statins, and nitrates might be prescribed. They should avoid NSAIDs, so educate them to use Tylenol for pain or fever. And if they have nitroglycerin at home, it should be kept in the original airtight container because light can break down that nitroglycerin. Also teach them about risk factor modification, tobacco cessation, diet, regular exercise, blood pressure control, and blood glucose control. Teach them about activity and exercise protocols. Sexual activity can resume based on the healthcare provider. Usually after an exercise tolerance assessment is completed. If they can walk about 1 block or climb 2 flights of stairs without symptoms, they can usually safely resume sexual activity. Also help with anxiety management, teach them guided imagery, music therapy, or pet therapy. And then also tell them about cardiac rehabilitation programs. The American Heart Association is a great resource. There's walking programs at the local malls. Mended Hearts provides education and support to CABG patients and families. Teach them about smoking cessation programs and weight reduction programs as well. So that is all I have for acute coronary syndromes. If you guys have any questions, please reach out to me on Teams or send me an email, and I look forward to seeing you guys at the Q&A.